turning to this hour, which will be much better because Heidi and I think Alex have turned up. Let me introduce briefly to frame this topic. And at the end, Bob is going to give us some notices, but I'll just do one since Jill is already present in front of my screen. So 21st of August, the third Thursday of August, at the same time, Jill will be talking about bringing a kindness approach to breastfeeding. And it's going to be Jill and Pied Piper, as yet not quite determined colleagues. So that will be, to use the vernacular, a corker. So Heidi, welcome. Thank you, not for just for what's about to unfold over the next hour, but for the fascinating conversation we had back in March when we met at the Edelman Trust Summit, and for your generosity in immediately saying, yep, I'd love to come to this group, and coming along as a participant a few times towards today. You are a fascinating person because you come with a lens of sociology, I think, social science and ethnography, perhaps, to this question of how the emotional determinants of health might link to kindness and how they might link to some really practical aspects of modern healthcare. And the conversation we had was grounded in vaccine uptake. And I think you're going to talk about that and more with Alex. But I was quite struck by we've just been reflecting on some moments in British public policy when perhaps telling the public that they are stupid and actively harming themselves. I was thinking about today, and sometimes we seem to put those labels onto people who don't do what we would want them to around vaccines. And you can give us a much richer tapestry of better, more empathetic and kinder behaviors and attitudes. I do want to give a little plug for your book, which is, I think, both scholarly and entertaining, and it's called Stuck. Although actually, there's quite a lot of getting unstuck in it. So thank you very much for putting that onto my radar. Let me just say, Alex will, I think, come afterwards, but Alex is a colleague of yours on co-leading the Lancet's Commission on the Emotional Determinants of Health. Alex, I have not yet met other than on email, as is too often the way. But Alex, I'm looking forward to meeting you properly tonight. And Alex is based in North Carolina at the University Medical School in Chapel Hill. And Alex is a transplant surgeon. And I'll make a little confession here, because one of the things I think Alex does, and I'm not sure if he's going to talk about this or not, but I had thought, because Alex does unrelated live donor transplants. So a typical example would be someone who decides to donate a kidney to a stranger. And that seems to me a pretty staggering act of kindness. And the lens around that is how it is both giving to the giver and the receiver. So Alex, I had secretly thought that you might do a session on that in the future. So just to publicly declare that, as well as thanking you for today. So our format, many of you will know it, but we're going to hear it in 10 or so minutes from Alex and Heidi to frame our discussion. Bob will then seamlessly move us into breakout groups, and we'll let you know the topic that we want you to focus on in there. You can, of course, focus on whatever you want, but Heidi's suggestion is that we explore the stories that we all have about caregivers' emotional distress and think about ways in which those have been managed either well or not so well. And what Heidi and Alex will say will enrich in that dialogue. And then at about 20 to the hour, we will come back into this forum and share some of the perspectives from those stories, hopefully with a bit of an action lens on it. To borrow from Jill, what are the lemon light bulb moments? So the things that really drive our ability to act as well as to think differently. So Bob, I will thank you in advance for mixing the decks, and flag your cruelty that you will bring people back just at the very moment when their conversations are at their zenith, because you always do. Heidi, thank you, and the floor is yours.
Thanks so much. And it's really an honor to be here. And also kindness really weighs into a lot of the work we're doing, or the need for it, certainly. I can I just ask, can I share slides, or it has to be from?
No,
No,
you
you can.
should be able to.
Okay.
Yeah.
I'm just gonna be back up for Alex talking. I'll I'll put them on when he starts. Um, I just this came up in the context of we're leading a Lancet commission on the emotional determinants of health, which Richard Horton had said to me, you know, I never thought of that perspective. And we've really been exploring it from, you know, we have neuroscientists, evolutionary biologists, people looking at how emotions can actually trigger health conditions, to how they can affect progression of disease, to healing, how they can affect political decisions, policy decisions. So I'm sure you know these commissions, you can't get into great depth in any one area, but the idea is to map and try to bring attention to this important field and destigmatize the idea that it's just emotions and you don't really have a problem, or you don't really have an ailment. So that's the framing. I've been strictly instructed not to spend too much time. But one of the bigger working, I think the working group where we're getting more in depth, which I'm particularly working closely with Alex on, is on physician and healthcare professional emotions, which Alex said it's almost like COVID gave us permission to have emotions, because everyone did, after being trained to have detached emotions. And we're also looking into interventions. Alex, I'm going to turn over to you and be your slide person. Is that okay? I think you're on mute.
I'm on
There
mute.
you go.
Okay. All right. First technical snafu. Probably won't be the last, but do our best. The first I just wanted to thank James and Bob and everybody for having us. I'm a relative newcomer to the Kindness Collaborative that you guys have organized, and you know, it's been a fantastic experience. But as a relative newcomer, I've still already seen I've been to a couple of sessions where we talked about shame, and within that, how we treat each other, right? How we treat trainees or how we treat our colleagues. We've probably in the past as well looked at how we treat patients, whether we bring that element of humanism to the bedside, and how we try to do that in spite of all the other pressures and challenges. But today, maybe we'll be looking at kindness through yet another lens, and that is sort of the kindness to ourselves that we would have. In our world of clinical medicine, obviously, sort of the global expectations of related to science, related to what the expectations our patients bring to the table, and of course our own expectations are very high in terms of having good outcomes. And with all those advances, we're probably less tolerant of errors than we used to be. Yet we know from the data that 1 out of 3 deaths, there's a component of healthcare errors, human error in all these, whether that's a pharmacological thing, whether that's a surgical complication, whether that's a communication breakdown between providers. We know that that's a major component of poor outcomes for our patients. It's just that human error. And, the question is, like, where do we, with the high expectations, do we have, how do we give ourselves the grace to be human, to do our best and still sometimes not have great outcomes? And in looking at sort of the emotional life of physicians in our project with Heidi, for the Lancet. One of the angles that we were going to focus on today was moral injury and second victim syndrome. And those are kind of overlapping phenomenons, but we usually, and I know others in the room would probably have even better definitions of these two, but the quote I think of when I think of moral injury is a Shakespearean quote of, "Oh, I have suffered with those that I saw suffer." That's sort of moral injury, witnessing maybe a situation where patients didn't come first and there's some dissonance there, or maybe we saw a poor outcome. But second victim syndrome in in shorter terms is, instead of witnessing the car accident, you were driving the car, or you were the one who cleared the brakes for the car to be on the road, or somehow you were more intimately involved in that poor outcome. And as far as a quote for second victim syndrome, I feel like this is the one that you see on the screen there is the one that kind of represents that. And being a surgeon, I guess I'm more familiar with the surgical literature, but that surgeon could be replaced with anything. It could be any provider. It could be a nurse, a pharmacist, physician of any sort, really. But it says here, this is René Lariche, a French surgeon from over a decade or over a century ago. And he says, every surgeon carries within himself a small cemetery where he goes from time to time to pray, a place of bitterness and regret, where he must look for an explanation for his failures. And it is a kind of a bit harsh with the cemetery referencing, but it's also, there's a lot of truth in that we can't always absolve ourselves from some of the mistakes we made, and it takes time and perspective to get there. That sometimes, as that quote says, sometimes it can be crippling or haunting, and I'm sure all of us have things that we wish we had done better at some point in our careers. Whether that be handling a conversation better or actually impacting an outcome of a patient. But when all of these things happen, we look sometimes to other fields. If you look at, say, the police force, you see these movies, but sort of based on some form of reality where, the grizzled lieutenant says to the young buck who's made a mistake, okay, Higgins, you've had a rough go of it lately. Why don't you come sit behind the desk with me for a few weeks and cool off, and then we'll get you back out there. So you see that. Sometimes you see the same thing in military with some people being shell-shocked, and then you see the flip side on the military as well, where the walking wounded, even though they're wounded, they're expected to be carrying as much weight as possible, get back out there. So I think we see different approaches in different fields, and today I figured we'd all sort of take a look, at ourselves, at our own private cemeteries, as you will, and see, how we felt in those moments, what we did to help ourselves, what others did to help us, or how do we, instead of ending up crippled from those experiences, how do we actually grow from those experiences and become better providers, more compassionate, and where do we find that kind of grace and kindness to ourselves? So that's this point, I guess, planning to turn it back over to our MCs and to James and Bob, and go from there.
Thank you very much. What an extraordinarily powerful quote that is, Alex. I have not heard it for a long time, but it comes back with immediacy, and I think it's interesting that it comes from, I think, the 19th century, but
yes,
it could just as well come from today. And I speak as someone who thought he was going to be a surgeon at one point, and is married to someone who is. But as you say, it's applicable to all of us. We have our cemeteries, real and virtual, and we should go there from time to time. So, Heidi, Alex, Heidi, you would like to add before we disperse?
Yeah, well, what can I say? I mean, one of the things that we really, aside from bringing attention to what we think has been actually an underaddressed, I have to say, when I started to go through, I mean, we've gone through a lot of literature and looked at things, and I was really stunned at the various letters to the Lancet from professional associations, medical, nursing, to the Lancet saying, we need help, we need support. And I think, it's something that goes way back to 19th to 100 years ago. But at the same time, we have a dramatically changed environment. It's much more aggressive. We have I think the whole, I won't take time here, but just the way the landscape has kind of squeezed out, as Alex said, the humanness of it. And I think we need to figure out ways to get that back. And the level of aggression, I mean, I've never seen so many signs saying, please treat people nicely, as if you need signs that, you don't do it instinctively. So just to think of the fact that, part of this is environmental, but it's very deeply personal also. So we do want to come out of these discussions with also hearing from all of you on ways that, if you either personally have stories or with colleagues, and what helped, because we don't want to come out of this commission either without, um, having some ways forward. And also happy to follow up with anyone after the conversation today.
Wonderful. Heidi, thank you. And you remind me, if Alex was talking about, if you like, the big cemetery things, I'm recalling 2 or 3 months ago, I think it was in Matt's session, we were talking about the micro aggressions of the notice that says,
I know.
this fridge is only for the acute medical unit staff. Keep out the rest. Okay. So, Bob, if you can
Uh,
head us towards our
I
breakouts.
yeah, I think the tech is looking okay, James. I think.
Okay, very good. So let me just recap what we hope people will find a route to discussion around. We'd like to hear about the stories that we all share about emotional distress of us and fellow caregivers, and how these have been managed, particularly thinking about ways in which this has been done well. And then we'll come back and have a wider discussion back with Alex and Heidi on that.
Fantastic.
And you're going to send us away for, I think, about 19 minutes.
Yeah, and we'll do exactly right. We'll do our sort of 20 to the hour piece on it. So you know the routine. And as ever, if you get lost on the way, just turn off your computer, switch it back on, and hopefully you'll find me waiting for you. Usually with there's a few renegades. I mean, people like Fred and Bimby. Don't know, there's something up with your computers. No one would choose to hang out with me in the main room than in one of the breakouts. But anyway, these things happen. Right, seatbelts on. These rooms are open. We'll see you at 22.
Thank you.
Thank you.
Now, are we still in the main room?
We're still in the main room, which means you're part of the beautiful recording and things. I think there might be something to do with external, something about external looking. Anyway, I haven't worked out the IT.
Here we are.
Here we are. Go on, James.
We are the 6 who were meant to be here.
Why don't you choreograph this a little bit and carry on the conversation? Because it's usually me who has to do this. So I'm going to relax. You get these wonderful people talking. We've got Alex with us as well, which is a mega bonus.
Yeah,
It's a
well,
bit like a roulette game, isn't it? Where
It's
it
just like
spins
a
and
roulette game. Yeah, I'm trying to work out whether this is the bullet or the no anything. You know.
yes, I was going to quit, Bob, that the prize for technical failure is 20 minutes with you. So
I know
here
exactly.
we all
Yeah.
are. Now, some of us know each other, some of us don't. So let's just quickly say hello. David, why don't you go first, and then Benedict and Katerini.
Hi, I'm David Freiberg. For those I haven't gotten to meet, I'm an endocrinologist and I run a nonprofit called Envision Kindness.
Benedict.
Hi, I'm Benedict. I suppose, primarily I'm a mum. I have 3 children who are now adults, all of whom have quite complex needs. The last one, 2 autistic ones, all mess, but the last one was a very medical kid. So I spent a lot of time in hospitals. And I now I set up a company called Tugboat Send Navigation. So I support families navigating disability services across education, health and care. I found it really, when I read your summary, Bob, and I read caregiver, for me that was unpaid carers, and I love the fact that we're talking about professional carers, because I'm always very keenly aware actually of the pressures that they can be under, the responsibility that they have. You know, when you have something's gone wrong in an operation or with a treatment, it's just as hard, isn't it, for you, maybe harder, I don't know, doing the prescribing as well as us who kind of on the receiving end and dealing with the impacts.
Yeah. Benedict, don't lose those thoughts. We will come back to them, but let's just let everyone say hello. Katerini, and then Alex, I realise I introduced you, but you, I'm sure, want to introduce yourself with some other elements. So let's not miss you out. And then Bob.
Okay.
So I'm a locum consultant physician. I was called to the bar by Inner Temple in 2023, so I'm technically an unregistered barrister. I've written a children's book, and I've passed the mediation kind of certificate, although I've never mediated anything. So yeah, I think that's. I think there's something else as well, but it's not the main thing.
There'll be many things. Thank you, Alex.
Yes. And again, I'm Alex Toledo. I'm a transplant surgeon here at the University of North Carolina. And like I said earlier, a little bit new to the Kindness Collaborative, and was introduced, fortunately, through Heidi and our work with the emotional determinants of health. And specifically, our little piece of that is looking at sort of the physician well-being and the kind of emotional life of physicians, some of the pressures, and physicians really is just because it's a Lancet readership, it's titled physicians, but truly it's all it's meant to reflect all caregivers in that.
Wonderful. And Alex, I loved what Heidi slipped in, which was that Richard Horton, who's the editor of the Lancet, said, "Oh, emotional determinants. I didn't realize that was a thing," and then launched a commission on it. I mean, isn't that very classic Richard Horton and indeed Lancet? Essie is in the room. I don't know if you can hear us, Essie, or if indeed you're the essay that I think you might be. But Bob, everyone knows you, but tell us something that people might not know about you.
Oh gosh, well that's wonderful. So I'm a paediatrician, you know that about me, and I have a wonderful role at Imperial, grappling with a wide and interesting strategic role. The thing that you don't know about me, well, you know that I rush around the place and have loads of different things on Friday, and I'd love to weave this into the conversation later, James. I was doing a talk up at the North Middlesex. I cycled up to go and see Nena, who's a wonderful hematologist friend and colleague who Alex, David, really brave leader, physician leader who runs an NHS trust in a complicated part of London. And I went to go, and they had a big day of improvement. I did a talk for them on kindness and on some of the evidence base and some of the things we've been learning. And I was asked this brilliant question. It's something that I've been thinking around, and I think links to this topic beautifully, was how do you slow down? And Alex, almost the point that you and Heidi were making when you were talking, I was thinking back to that question. And I'm 100 miles an hour and an extrovert, and I love ideas and I riff off people and stuff, but I've definitely got curious about how to better slow down. So on a very busy ward round where there's a lot of patients still to see, how do you actively slow down, sit on the end of someone's bed with permission and just give the impression I've got genuinely the whole day to listen to you if I need to. Now I don't, because I've still got 24 patients to see, but I'm intellectually and practically very, very interested in this thing, because it allows those human moments of touch, of listening, of compassion to happen. So it feels to me, Nish Manek James, lovely friend, I'll try and dig it out, wrote a beautiful little piece about the badge of being busy. So I'm trying to find this sort of too busy to be human piece is worth it. Well, anyway, they're things that are top of mind for me.
Okay, so I'm James Mountford. I live in London. I have a medical background. I do a bunch of things in and outside of healthcare, but I think one of the most interesting things for me at the moment is I'm training to be a coach, and that has led me to reflect on myself. And on my mother's side, I'm the son of a baker who left school at age 14, who was, I think, quite wise in a, if you like, not formally educated sort of way. And you made me think, Bob, of something that my granddad, Fred Walsh, his name was, from Wigan, used to say. He said that on busyness, because he often thought that I wasn't spending my time on the right things, shall we say. And he said, if the Queen said to you, come to tea, would you say you were too busy? And his contention was, no, most people would not. If Bob and I supporters of Southampton Football Club, if we were invited to have the best box at St Mary's, would we say we were too busy? Even after last season, Bob, no, we would not. Lovely. Now, Essie, you come in when and as you can, but we will move into the next phase. So, I thought anyway. Benedict or anyone, can we come back to you and continue that lovely line of thought, if you would?
So one of the things, as the mother of a kid who was ill most of the time, he's alive, he's nearly 22, superb. But I found that relationship, it's complicated by having a mum in the middle. You've got a patient, a parent, and a clinician, and we're having to communicate often very fast. And Bob, I really hear what you're talking about. How do we slow down? And it's ever so easy to become quite adversarial, and who is right, who is wrong. And especially if medicine isn't fixing things, it's really easy as a mum to be worried and heartbroken and tense about your child. I have yet to meet a parent carer who isn't ill. I had a very interesting experience just this week. One of my friends has been really, really ill. She had spinal surgery, it's gone well. But I have had the most excruciating, screaming level of pain in my arm. There's nothing physically wrong with my arm, but my brain doesn't allow me to feel emotion anymore. And so it's coming out in my body. So there was all of the emotion that I have to process. But I've always been really aware of the fact that on the other side of the table, there's a doctor who is trying to make sense of a complicated situation and is having to make sense of a treatment that didn't do what we hoped. And trying to find that emotional connection with a doctor as a patient or as the mother of a patient, I've found very difficult. Occasionally I've found it, and it's been magical when it happens, because we're there as human beings going, this is difficult. Nobody's to blame. What do we do next? And how do we sit with that difficult emotion and be kind to each other?
I mean, this is for everybody. One of the things that I have been really quite struck with over the last few months is this question of being vulnerable in front of people who you don't really know. And I guess my growing insight is that that vulnerability is most easy to display from a place of confidence. So the more confident you are, the more ready people seem to be vulnerable. I'm not necessarily thinking of clinical contexts here, but to build trust, vulnerability is so important. And I think you beautifully described it, Benedict. And indeed, Alex, in your intro, you did. Does that spark anyone with a thought?
Yeah.
I'm really interested, James, because the only thing that I've ever felt confident of is my complete ignorance. and the fact that, yeah, I have no idea, but I know that given my situation, I'm going to do best if I can be completely open and vulnerable. And I take risks. I take risks that, say, if I can't look after my kids, the social worker might take them away. But maybe there is a confidence in that. It's really, really, it's made my brain go, ooh, yeah. That was a word I wasn't expecting.
I think also it can be, I don't know if the word is liberating, but I do think that there's a burden that can be removed when you are willing to put some of those vulnerabilities out there, like you said, James, in terms of, at a clinical setting, if you're at the bedside, it's okay to say, you know what, I don't know. I'm not sure what's going on here, but here's some of the things we're going to do to try to figure it out. And, I think sometimes that can be, at least for me, I think sometimes that can be a little bit more liberating than trying to pose as someone who has all the answers.
Can I come in? And David, it'd be great to bring you and Katrina in. One of the things when just flipping another side of the coin, we've done quite a lot about poor behaviors and recognizing that time and again, and James, this plays into your career choices about coaching, they come from issues around self-esteem and people's own difficult things going on at work, going on at home. Maybe back to your quote, Alex, about the cemetery feeling a bit full and a bit live and a bit close, and that can drive some of the poor behaviors. It strikes me that in order to be vulnerable in the way Benedict, Alex, you guys have described, you have to have a degree of comfort in your own skin about who you are, and just to play around. David, come on in. You've been super patient.
Yeah. Very polite, David.
Thank you. It's really, as you're reflecting, and what Alex, I heard you talk about is humility. Yeah. And humility grows from two sources, right? One source is it's confidence, but really it's knowing who you are and what you are, and the willingness to accept imperfection. Right? Most physicians in particular are often trained that they have to know the answers. They're put under the pressure to have to know it. So that goes along with how connected I feel, to your earlier comment, Benedict, to others. If I feel connected to you and I therefore trust you and you trust me, then it's easier to allow for that to happen. In the US in particular, also, we were trained not to admit what we didn't know, because that was actually done legally, and it was misguided in its attempt by lawyers who said that you would get sued if something went wrong. And so it's kind of like admitting that you made an error. And in fact, it's just the opposite, right? Patients often sue less when the doc has said, sorry, I made this mistake. But Bob, your earlier points, and I'll close it out, try to give everyone a chance, is there's too much stress for folks. To me, stress is actually where a lot of this starts. you're imposed upon with too many obligations. And what you really want to do is sit at the bedside and talk to patients. And there's a pressure because maybe you're on rounds with the house staff or the registrars, whomever. And they've got to move on, and everyone's got their own pressures. And then there's too much information and many demands. And what happens, and Benedict, to put it in perspective, is people don't think well. They make more mistakes. And so stress in all of its different forms is an aggregate, and what some psychologists, a fellow at Rockefeller University, used to call allostatic load. And when it's too much, you don't speak well, you don't listen well, you don't think as well, medical errors are made. So finding ways to reduce stress is clutch. And that's why, and Bob and James, you've both heard my diatribe on this, but that's why I'm so fascinated. We make media about promoting kindness, and it works really well to lower stress. And that's our focal point, because it works so well, and then allows that person to be more in that moment because they don't have as much rumination going on. Anyway, I'll stop. Thank you for...
James and Katerina, you guys, we've got 2 minutes and then we're going to get the gang back.
Well, exactly. I mean, so many people have said so many things, so I'll just mention the snippets that appealed. I think from the patient's point of view, I think with difficult situations, particularly when you've got carers who are stressed themselves, I don't think as doctors, it's realistic to expect them to be always rational. So if you're looking for the other side to be sort of shifting on that, it's not going to happen. It'll be down to us. So coming back to some of the comments from the last two speakers, so our side of things is psychological safety again, so that when you're in an environment that is not hostile, your stress levels come down, which gives you a chance to think carefully what you're doing, what you're saying, and how you're communicating with people. I love sitting on the end of the bed, but I've been told off by infection control too many times. So you end up sort of cowering over the bed, being quite uncomfortable, trying to have a conversation. I find that it is useful because it does show juniors that it is important to be on a human sort of level with people. And then my last comment is just honesty and candor about things. And I was at a conference, an online conference, where a neurologist was explaining how they now speak about functional neurological disease. And I thought that was very well done. And what they tend to say is they tend to explain that, if we don't find that whatever the EEG or the whatever the tests that they're doing are going to be conclusive in one direction, then it is very likely, and actually it's more of a positive diagnosis, that when the brain experiences pain, it is a protective thing, and it is there in order to prevent further injury. So it is kind of explained to the patient that, if we can get into that cycle where this is it's not a put on syndrome, it is a very real pain because the brain is expecting to feel that pain in order to protect the body. So I think there are strategies and honest ways of speaking about things that help, and it certainly diffused something this week for me because I was able to tell someone about that might be a possibility when she came straight out and said, could it be NFD?
James and everybody, I'm going to bring everyone back.
Yes, Bob, you need to be cruel now.
It's cruel everywhere. It's tough in this room as well. I shorten.
Thank you, everybody, for the last 20 minutes. And hello, Sebastian.
And Sebastian, hello.
Out and about.
Yep, out and about, like walking meetings. I have a walking session here, which actually helps my brain think, moving about. So has hopefully some positive effect.
Wonderful. So everyone's rushing back. Bob, give us a nod when you think.
Yeah,
everyone
I
is
think, I
back.
mean, you know me, I count everyone out, I count them back in. It's like, being a farmer in the Welsh mountains or something. But I think we're looking good, James.
For those of a certain age, that was Brian Hanrahan, the BBC reporter who was on an aircraft carrier in the Falklands conflict, who wasn't allowed to say how many Harrier jets had gone off, but he was allowed to say that they'd all come back. Anyway, the 20 minutes in the group I was in just flew by, and my head is buzzing. So at this point, please hands up or just speak up, and share some insights from your conversations, please.
Well, I will invite, from our group, we had a fabulous conversation. We all, I think, inspired each other. But I asked Chris Turner to give a brief overview, and hopefully we can ask Chris to spend more time at a future session going into more depth on what he discussed in our group. But Chris, would you just say a few words about rumination and reflection?
So I'll make this as quick as possible, but every time something happens to us, we make sense of it. There's a wee black box in our heads making sense of it. And I am really privileged. I get to read the sense that my trainees have made of something that has happened. And I read it, and I realize that an awful lot of people confuse two different processes. They call it a reflection, but actually what I'm reading is the self-flagellation of rumination. Something has happened, they're ruminating on it, they're doing it on their own. And rumination is an interesting process, because what happens is we think about the thing that went wrong, we spin back to the index incident, and we have all the feelings again, and it feels horrible. It's probably essential for most human beings to ruminate. We need to ruminate. But it can become pathological. It can lead to PTSD, anxiety. It can become crippling. And what we hope that people will get to eventually is reflection. Reflection, and Alex, you mentioned this earlier, reflection is the thing that can lead us to growth. Now, sometimes reflection doesn't lead us to growth. What it does is it leads us to acceptance, because there are some things that are so bad, all we can do is accept. And so rumination is a highly emotional, triggering, going round in a loop. We often do it on our own at 3 o'clock in the morning. Reflection, on the other hand, tends to be a bit colder. It's a wee bit more logical, and the evidence around it is we're better doing it with other people, because on our own we get stuck in a dark place. And the road from rumination to reflection is paved by trust. If we're going to let somebody help us to go from rumination to reflection, we have to trust them and believe in the purity of their intent. Now, there's a lot more to this, but I find it a really useful space when I'm sitting with people who have been through something really difficult to understand it. I'm thinking, are you in a ruminating phase? Or are you in a reflective phase? And who do you need me to be at this moment in time with you? And am I going to sit with you? Am I going to bear witness? Or are you in a space where you're okay with me being more of a reflector, challenger kind of person to help you to think about this situation? So
thank you so much, Chris.
Chris, that's absolutely fascinating. And Susie is waiting, I was going to say painfully, I mean patiently, with a hand up. But Chris, can I just ask you, before we go to Susie, vulnerability may have come up in many of the groups. It came up in our group as a platform for trust. So we show vulnerability in ourselves to create the opportunity to build trust, which requires others to be vulnerable. And by trust, I think what we meant was reliability, not reliability as in we'll do what we say, but that we recognize that we are happy to bring our shortcomings and uncertainties into the arena between us, and for it not to be used against us. I think that's sort of what we meant. We didn't quite articulate that. So my question to you, in your privileged place as the head of this busy emergency department, what do you do to help pave the road for an individual between rumination and reflection?
So the building of trust.
What do you do to, yeah.
So building of trust, Joseph Folkman writes about the building of trust, 3 components. The first one is to be competent at the thing that you are doing. So you trust your electrician to do it, the electrics, but you don't necessarily trust them to play lead guitar in your band, because you might not play guitar. You believe somebody is competent, that they are consistent. And consistency is really important. It's hard to trust people who are inconsistent in their response. And the third thing, and I think it relates to the second thing, is the building of relationship. It's not something you just get like this. And we have a problem in healthcare, and that is that we believe that we should just be trusted because our patients just trust us. But actually, that's not the case in other relationships. Other relationships, we build trust in it. And that means building the social capital, spending the time with people, getting to know them. And Susie, I'm really sorry for coming in. I think you were actually in there first.
No, not at all, Chris. Thank you.
No apologies. That was all fascinating. And I mean, in our group, we had just such a wide-ranging discussion. It was really, really interesting, and we could have gone on for a lot longer. But I just wanted to share 1 or 2 points. We heard a lot about system factors, and where it's you know, the kind of cruelty of system factors being poorly designed that result then in a personal impact, and the emotional labor that then is visited on the individual from something that is really a system level wound. So you know, that can be looked at very clinically, but that kind of QI kind of system level analysis often doesn't do the work of unpacking the labor, the emotional labor that has been the wound. And what I hear in my work is, well, firstly, bad things happening to good people, but then good people deducing that they're the problem. So this inability to separate what's happened at work and at work as a process from personhood. And if we're going to translate it into solutions and where this has ended well, I think it's all about safe spaces. I mean, Chris has just talked about the building of trust, but you know, for us in leadership, we talk a lot about compassion, self-compassion, but building that into processes. I'm sure lots of you know about the compassion processes and the sort of 10-minute pause and the debrief, the structured debrief that exists. But it's really weird, isn't it, that doctors go through their professional lives without supervision unless they're psychiatrists, and yet all of us are coming across you know, really challenging situations. And I'm sure I'm not the only one whose mind was going to the worst possible scenarios that I've seen and witnessed and been part of in my clinical career during this really interesting talk. And so just to have a safe space to unpack that, which is validating, which is led by somebody who can also acknowledge their own vulnerability and fallibility and model that as kind of reasonable leadership, and just to explore what it means to be human. I think there's something about humanity in all of this and showing up fully as people, you know, sharing anecdotes, sharing stories, also using other disciplines like, you know, poetry and the arts and music where possible, I think. I'll leave it there. There's probably lots more to say, but I'm conscious of the time.
I want to ask Bibby to come in here in our group, because he had a really powerful story on just what you pointed out, what it means to be human, starting out as a very technically driven, wanting to impress others. And then when humanity hits, Bimby, over to you.
We've got another 20 minutes.
No.
So
I know that was a risky.
Essentially, Alex, I know what it's like to do multi-organ retrieval And going out as a brash, eager to impress surgeon, I lost touch with humanity because I was thinking of doing the operation to impress and get through to the other side. Essentially, it was on a young donor, and a young donor that I blanked out because I was trying to protect myself whilst focusing on the endpoints of safely procuring the organs for the recipients. And it was when I was tripped up by a teddy bear that fell to the ground as we were taking the drapes off the patient that it suddenly hit home. And I realized that actually I was emotionally disconnected from the donor. And it took me a long time to recover from that personally. And I went to that cemetery on numerous occasions and have sort of talked about this in Schwartz rounds. Even in the preps for the Schwartz rounds, I found that I've been crying, on a few occasions when I have had to practice that, and so it is something where when you lose touch with your humanity in healthcare, it really does hit home. And of course, being kind and trying to find ways of practicing self-kindness, I was trying to rationalize the fact that I was doing the job for the other recipients, the responsibility to the parents, and even for the donor themselves, to get the best outcomes. But divorcing that from the fact that my mental focus was really just to get in and get out as smoothly and as safely as possible really hit home. And that's just something I thought I'd share again.
Thank you, Bimby. That's quite something. Bob.
Well, yeah. Listen, I mean, Alex, do you want to come back in on that? Because I saw you nodding and I've got a 30-second piece that I just want to share with something from somebody who's not here, but who I'd love to be here. And but Alex.
Oh no, that really what Bimby was talking about really resonates. I've had similar experiences on a donor. A lot of times, you're focused on, and sometimes it's a benefit to really hone in on what you're there to do to get your task done. But yeah, then I've had cases where, like you said, you peel the drapes off and, we had an abuse case one time. You peel the drapes off and you see the cigarette burns on their chest and neck and back that you had never appreciated before, because you got in the room after they were prepped and draped and ready for surgery, but you didn't realize, those kind of things definitely, hit home when it takes you from technician mode back to being a human being and realizing what that patient went through, what they went through, and why they were a donor in the first place, right? That in my case it was child abuse, that head trauma. So yeah, some of those are really it's hard to do. It's a difficult balancing act sometimes, I think, to do your job, and doing your job is important to a bunch of other people downstream, but also having that moment that's pretty hard. And I'm sure in the emergency room and other places, it's probably even more difficult.
Yeah, and the sort of meta question becomes, what is the actual job? Whose measure comes on. I just want to flag a wonderful friend, close personal friend, who was one of our trainees here at St Mary's. She's got Nish Manek. Some of you guys will know, GP in Cambridge. Nish has got young children, and so she always teases me and says, I know, look, Kath is looking at this going, this is a ridiculous time, but for Nish with young children, 6 till 7's a toughie. But Nish sent a really great blog out to her national group of GPs. I put it in the chat. You'll just have to scroll back a bit, about the word busy. And Nish and I independently, and we started to riff off each other a bit on this, have got very curious about, and Nish has written this brilliant few words, and she writes so beautifully about the badge of busyness. And I think, as we were chatting in our small group, there's something for us to the busyness badge sort of gets in the way of those human moments, of those listening, of those piece. So I think it's a brilliant challenge from Nish around this. Just reflect on it when you bump into people over the next week and you ask people how they are. The word busy will come up. I don't know, 2/3 of the time people will tell you, oh no, I'm really good but busy, and it's like, what does this word really mean? So yeah, we're having a bit of fun with that, but it feels like this piece about slowing down, and Sunny, your beautiful poem sort of hints towards that. How do we slow down feels important. James, I'm going to pass to you to have a last word, and Heidi and Alex too, and then I'll do a 10-second wrap to finish us off.
Right, well, Heidi, Alex, I'd love a closing thought from each of you. Mine just picks up, other than my grateful thanks to the many people in the room right now, and you and Alex and Heidi for feeding us with such rich mental fodder. You mentioned the word grace, Alex, and busy and grace don't go together in my mind, and true masters of whatever art, I think, behave and convey a sense of grace. You know, you might think about Lionel Messi, you know, to take an example away from health. So that's something I might noodle away on. Heidi, Alex, can you give us your closing thought, please?
You want to go first, Alex?
Sure, I can go first. I think Chris summarized part of, you know, what I would say in closing really well, is that, you know, we have these difficult moments that are really unavoidable, you know, being human, and we kind of have to embrace the humanity of it. And that's the great moments when we help people tremendously, and that's the moments when we either fall short or are just incapable, you know, are you know, can't get to the outcome we want to get to, whether that's you know, whether we think of ourselves as culpable or not. You know, there can be some sort of dark moments in there, and I think with I think we want to stay there for a moment, kind of like Chris said. We want to ruminate for a little bit. We don't want to absolve ourselves too quickly, but at the same time, we do have to function forward and move into the reflection phase, and find people that can help us to do that, or find our own mechanisms within ourselves to do that. And I think that's probably the most important part is, you know, the goal is not to not feel those thoughts of doubt or of you know, wishing you had done better, but as Chris said, that you somehow come to a point where you can accept that and even grow from that.
Thank you, Alex. Heidi.
Thanks. And I'm going to pick up just a bit on just one word on the trust. I mean, a lot of my work is on trust and trust building, but also what I'm spending more and more time looking at what people characterize as trust, what drives them to trust. And motive is a huge thing. I mean, there's the competence, and can I trust this person's going to deliver what they what they say they can? And the other is, what's their motive? Are they really here? Do they really care here for my best interest, or are they putting another buck in their pocket? And I mean, this kind of trend issue has been a big issue with vaccines. Are you just here to check the boxes off and get a little incentive for giving another jab, or do you really care about my life? And in general, I think that it's led to suicide. I mean, not suicides, patients actually killing some doctors in China because they didn't trust their motives in the transition from a, you know, communist system to a partly pay system. And, you know, it changes the dynamic. So I think people, that human side that you're talking about, bringing that out, people pick it up. They will know the difference if you're there as a technician or if you're there with, I mean, they also respect the fact that you need to do your job. And if you get emotionally involved with everything, you wouldn't get through the day. But just to think, just to throw in that perspective from a bit of the patient side or the other,
Thank you,
another
Heidi.
doctor's side. Yeah.
Heidi,
Thank you.
Heidi, Alex, wonderful. Thank you so much. We've hit the hour and again on the button. Thank you for an absolutely wonderful bit. My final reflection goes to Benedict. Scroll back up that chat. Benedict, lovely to meet you. You've written something beautiful. I can share that I love the human doctor's best. I don't need you to never fail. I need you to see, to hear, and to find next steps. Thank you to everybody who's come and joined us. What a fantastic hour. Heidi, Alex, so much for us to think about. And listen, James, we've got a fantastic month ahead, and Jill, very excited. I'm going to be on the North Norfolk coast, maybe sort of finding a bit of copper and a bicycle to try and get some sort of signal. I'll work it all out. And thanks, everybody. Have a great month, and we'll look forward to seeing you this time in a month's time. All the best.
Thank you. Thank you.
Thank you, James. Thank you,
Yeah.
Bob. Everybody.
Hi, guys. Have a good night.
Thank you.